Today's course is Vision Screening Training for Georgia School Nurses. The training which follows is for school nurses and public health staff who screen in the school and public health settings. The training is being provided by Prevent Blindness Georgia. Prevent Blindness is a nonprofit voluntary organization founded in 1965 by a local ophthalmologist. We're part of a national organization called Prevent Blindness America. Our mission at Prevent Blindness Georgia is to prevent blindness and preserve sight through vision screening, training to vision screen, and public education. We offer early detection screening programs for young children, as well as adults at risk for vision problems and working poor and homeless people. We also provide vision screening training for school nurses, public health, pediatric office staff, and nursing students. We also educate the public about vision problems and the need for regular eye exams. My name is Laurie Irby, and I'm Vice President for Children's Programs at Prevent Blindness Georgia and have been screening and training others to do vision screening for 18 years. These guidelines are as of January 2014. We are expecting new guidelines for young children, those ages 3 to 5, to be released by the National Expert Panel of the National Center for Children's Vision and Eye Health. Until then, we recommend that you not purchase any new screening tools, but that you go ahead and implement any guidelines you can without making purchases. Remember, however, that the new guidelines will relate specifically to young children, those in kindergarten and in pre-K, and most of you will not be impacted by these changes in guidelines. The following presentation is arranged with general information at the beginning and the end. Everyone needs to review these sections. If you are studying only one section, you will still cover everything you need to know to administer that test correctly. So you may study only those tests that you need to know for the particular age group you're testing. Guidelines are provided for all ages, so you may use these guidelines for screening children ages 5 through high school. And while you may choose to study only the particular test you need to administer to the age groups you serve, if you are an RN who plans to sign Form 3300, the Certificate of Vision, Hearing, Dental, and Nutrition screenings, you must complete all sections of the training and pass the certification test. When you complete this course, you will understand the importance of vision screening. You'll be able to recognize signs and symptoms of vision problems. You'll know how to conduct screenings, either for individual students about whom you're concerned or as part of a mass screening program. You'll also be able to interpret the screening results and make referrals when appropriate, and you'll understand the importance of follow-up on those children who fail the screening. Because lots of children are in a given school, school nurses have an excellent opportunity to detect vision problems as part of a mass screening, based on referral from a teacher, or simply by being in the school and observing students as they come and go. There are 8 sections in this course. The first section covers general information about why we need to test children's vision, how vision works, and what some common eye problems are. This section also covers information about how to implement a vision screening program in your school, the tools and supplies you will need, as well as the type of screening space you will need. The next section covers signs and symptoms of problems that you can observe. We refer to these as the ABCs. That's appearance, behavior, and complaints. Section 3 covers distance acuity screening for young children, those ages 3 to 5. You will need to study this section if you will be testing children in pre-K and kindergarten. I mention the age of 3 simply because there are different referral criteria for this age group, and you need to be aware of that. Section 4 covers distance acuity testing for children ages 6 and above. Some kindergartners will fall in this group, while some kindergartners you test will be 5. So you'll need to be aware of a child's age before you decide what the screening criteria are. The Random.E test you will conduct on children in grades pre-K through 3rd grade only. The Random.E stereopsis test is basically a depth perception test. Color vision testing will be done once on children ages 6 through 9. So you will either screen them when they turn 6 or the first time you see that child if the child has never had a color vision test before. Section 7 is near vision testing. Near vision testing should be done only on those children who are being evaluated as part of a response to intervention process or for special ed evaluation. Near vision testing should not be done as part of a routine screening or part of mass screenings. The final section will be a post-test. This is a certification test, and with successful completion of the certification test, you will be certified to vision screen for 3 years. This certification is required for RNs who need to sign Form 3300. So why do we need to conduct children's vision screening? Well, first of all, vision problems are the leading disabling condition of childhood. In fact, 1 in 20 preschool children has a vision problem. 1 in 4 school-age children has a vision problem. That's lots of children with vision problems. Children are often unaware that they have vision problems, especially young children. The way they see is the way they've always seen, and they don't know that they should see differently, or that they could see differently, or that other people do see differently. Older children may have figured out that something is wrong. Likewise, parents often don't know that their children have vision problems. They generally can't just look at them and tell. And because vision problems don't hurt, children don't complain about them, so the parent really has no way of knowing. Especially for young kids who are trying to learn the alphabet and the names of everything under the sun, not being able to see is a tremendous handicap. 80% of what a young child learns is visual, so vision is just so important to progress, not only in school, but poor vision can affect development of physical skills, cognitive and social and emotional development. Vision problems can lead to underachievement at any age. Consequently, vision screening plays an important role in detecting and preventing serious problems that can lead to lifelong and irreversible problems. And just as with other problems, early identification and treatment reduces complications and leads to better outcomes. Never feel bad about referring a child to an eye doctor. Too much depends on good vision. What we're going to learn today is how to do a vision screening. Vision screening is not the same thing as an eye exam, and it absolutely does not replace going to an eye doctor. Vision screening is a systematic approach to identifying children at risk or with potential vision problems. It helps us identify those who need to see an eye doctor. Most likely, we're going to identify the problem that might have been identified otherwise, just because, as we covered in the earlier slide, neither children nor parents recognize problems frequently. We'll try to educate parents along the way about eye health and signs and symptoms of vision problems. And the result of this screening is that if a child fails this screening, the child will be referred to an eye doctor for further evaluation. A screening does not diagnose a problem. It's when the child goes to the eye doctor for an eye exam that the doctor will do a comprehensive test and diagnose any problems if there are some, and then prescribe appropriate treatment. This training program was developed by Prevent Blindness based on medically accepted and scientifically tested screening techniques and technologies. In order to get accurate results, you must follow the specified procedures. There are several components to the screening. First is simply observation of the child for signs and symptoms of vision problems. We'll look at the child's eyes, observe the child's behavior, and listen to any complaints he may have. Each child will have a distance acuity test with an eye chart. There will be a different chart for young children, and then a second chart for children ages 6 and older. Younger children will have a stereopsis screening, which is basically a depth perception test. Children through age 9 or 3rd grade will take the stereopsis test. Color vision testing will be administered once, beginning at age 6, and generally will be conducted on children ages 6 through 9. Near visual testing will be done only on children who are being evaluated for RTI or special ed. The final report, part of the screening, is a report to parents and follow-up. This is a very important part of the screening because it doesn't do us any good to screen all of these children unless the ones who have problems receive treatment if they need it. Now let's talk about the nature of sight. Vision is learned from birth through age 7 or 8 as the brain receives normal visual experiences from each eye. Light rays reflecting from objects that we're viewing pass through the pupil to the back of the eyeball. If those images land precisely on the retina, which lines the back of the eyeball, then we have clear vision. The optic nerve behind each eye then transmits images to the brain, and the brain merges those images, thereby enabling depth perception. If the brain receives two confusing images, if, for instance, one image is clear and the other is blurry, or if the two images are of different objects, then the brain deals with that by suppressing the vision from one eye. And if this happens by about the age of 4, there can be permanent vision loss, especially if the problem is not treated by about age 6. For vision to develop normally, eyes must be healthy. They must both be straight so that the brain receives similar images from each eye, and both images must be sharp and clear. So what interferes with normal vision? If anything blocks the passage of light through an eye, such as a cataract or a droopy eyelid, if the child has an eye that's turned, or if the brain is receiving a blurry image from one or both eyes, then normal vision may not develop as it should. So what are the most common vision problems? Well, the most common is a refractive error, and a refractive error simply refers to a defect in the optics of the eye that prevents precise focus of light rays on the retina, causing blurred image. The retina lines the back of the eyeball, and you remember that in order to see clearly, the images being reflected from your two eyes must converge in a precise point on the retina in order for you to be able to see clearly. If the images fall short of the retina, then you have myopia or you're nearsighted. You can see well close up, but not so well at a distance. Myopia is the most common refractive error and affects about 25% of the population, and it usually becomes evident not until a child is about 8 or older. Hyperopia occurs when the images converge beyond the retina. Hyperopia, also known as farsightedness, means that you can see well at a distance but not so well close up. Astigmatism occurs when the curvature of the cornea or lens prevents light rays from focusing on a single point on the retina, and then your vision may be blurry both close up and at a distance. The treatment for refractive errors is glasses or contact lenses, which bend light rays so that they do converge properly on the retina. Another common vision problem is called strabismus, and strabismus occurs when eyes are misaligned or they're not straight. You've seen children who have an eye that turns in or out. Strabismus affects one or both eyes. It may be constant or intermittent, or it may alternate eyes. It affects about 3 to 5% of the U.S. population and can result in permanent vision loss if left untreated. In young children, the appearance may vary from day to day or within the same day, but is most pronounced when a child is tired, ill, or upset. Each type of strabismus has a different name. As you see in the top example, an eye turning in, that's called esotropia. When an eye turns up, that's called hypertropia. An eye turning out, as in the bottom example, is exotropia. There's not an example here, but an eye turning down is called hypotropia. Esotropia is the most common type of strabismus. There are several causes of strabismus. There may be a faulty muscle attachment. The child may have had a birth injury or some other type of injury. It may be caused by heredity, illness, or excessive farsightedness. Treatment depends on the cause. If a child has a faulty muscle attachment, the child may need surgery. But if the cause of the problem is excessive farsightedness, the child may just need a pair of glasses. It's critical that strabismus be diagnosed and corrected at an early age. Otherwise, it may develop into amblyopia or lazy eye blindness. But be sure, strabismus doesn't just go away. Amblyopia refers to reduced vision in an eye that has not had adequate use during childhood. Strabismus affects about 2 to 5% of the general population, and it can cause permanent vision loss if it's not treated early. Amblyopia may be caused by an unequal refractive error when there's a significant difference in vision between the two eyes. It may be caused by strabismus, or it may be caused by other factors such as ptosis or cataract. Treatment depends on the cause of the problem. It may be glasses, the child may require surgery, and/or the child may need patching to encourage the brain to start using the weaker eye. Now let's talk about implementing vision screening in the school setting. Obviously, if you're going to do vision screening, you need to have some screeners who have been trained to do the screening, and that's why you're here today. You will need to obtain the proper screening tools and supplies based on the age group of the children that you will be screening. You will need to prepare proper documentation forms so that you will not only be able to record the results of the screening, you may need to send permission letters home in advance of the screening, and you'll need parent notification letters to let parents know the results of the screening. The screening location is very important, and we're going to talk about the room requirements shortly. And you'll also want to define your procedures for rescreening children who failed the initial screening and for follow-up. Let's talk about the tools you're going to need for screening. Remember that the tools you need will depend on the age group of children you will be screening in your particular schools. Each child will receive a distance visual acuity test. A Leah Symbols chart will be used for children in pre-K and kindergarten, or at least those children who are up through age 5. An HOTV chart or a Snellen chart will be used for older children. Notice that we're recommending 10-foot charts. And there is one chart that's available that has Leah on one side and HOTV for the other, on the other. So if you are in an elementary school and you're screening younger children, you could buy that one chart and have both of the charts you need for all age groups. The second test you'll need for children in kindergarten, in pre-K through 3rd grade is the stereopsis test, which is called random.E. You'll need a color vision test. We do recommend a test called Color Vision Testing Made Easy. And if you're doing special ed evaluations or you're working with children in the RTI process, you may need the Leah Near Vision test. If you have these tools at your school, it would be a good idea for you to grab them now, as they will be handy for viewing as we go through this course. The following is just a list of some general supplies that you will need as you do the screening. You will need the documentation forms that we've talked about before. It will be helpful if you have these screening instructions handy. You'll need a measuring tape, masking tape. Happy feet aren't absolutely necessary, but younger kids enjoy standing on the happy feet when they are doing their testing. You'll need occluders, and the occluders may be a small Dixie cup, an index card, an orthoptic eye patch. You might also choose to use occluder glasses instead of other individual occluders. You can also use the plastic occluder that you've seen eye doctors use. If you do use that type of reusable occluder, remember you will need to clean it between every child. Consequently, disinfectant wipes will come in handy. You'll need a pen, a pointer. At Prevent Blindness, we use a pickup stick as a pointer. A clipboard is helpful. Tissues may come in handy. And if you're administering the color vision test, you may need cotton swabs or some small paintbrushes. Disinfectant wipes will also be used to clean the frames of the Random.E Stereopsis glasses. Remember when you do vision screening that you should follow precautions for infection control. Clean your hands before you screen children. Remember to clean the frames of the Random.E glasses and any reusable occluders or occluder glasses that you use. And do defer screening sick children. They're probably not going to be at their best when they're sick, and it's better just to minimize contamination by not screening those children. The screening room that you will need really should be quiet and free from distraction. I understand that it's sometimes very difficult to find such a room in a school, but you're going to have the best results if you do have a quiet room. It's best if you have an uncluttered, non-patterned wall on which to hang an eye chart, and you will need at least 12 feet of space. The children will be standing 10 feet from the eye chart, and especially with younger children, you'll probably have a helper who will be standing behind the child, so you'll need a little extra space for the helper. The room needs to be well lighted. It doesn't need to be excessively bright, but remember, we want the children to be able to see the eye chart. And you do need to be aware of glare shining on the eye chart or making it difficult for the child to see the chart or the Random.E test cards. Now let's talk about the screening procedure. First, there are several things that you will want to know before you begin screening. You need to confirm the child's age to determine the particular eye chart you should use, and also to identify the particular criteria for the distance acuity test and the other tests you're conducting. You need to determine whether or not the child wears prescription glasses or contact lenses, and you will note whether or not they are being worn for the screening. Generally, glasses should be worn for the vision screening because we know that the child is under care, but we want to make sure that the glasses are doing the job they're supposed to be doing. You should also note any symptoms or concerns noted by the teacher, and also any known vision problems or family history of vision problems. The actual screening will then consist of observation of signs and symptoms of vision problems, the distance acuity test for all children, the stereopsis screening, a color deficiency test if the child has never had one before, and near acuity for RTI and special ed evaluations. The next step will be rescreening as necessary for those children who fail the screening. The rescreening should be done within 2 or 3 weeks. If absolutely necessary, it can be done on the same day. However, you should give the child some time to rest before you do the rescreening. The next step is to make appropriate referrals to eye care professionals and then to follow up with the parents as needed on those children who failed the screenings. There are some situations when you should refer a child to an eye doctor immediately for an eye exam instead of just the screening. Any child who has obvious evidence of a physical abnormality, such as strabismus, ptosis, which is drooping of the eyelid that occludes vision, or nystagmus, which is constant movement of the eye back and forth, should be referred to an eye doctor for an eye exam. Children who have central nervous system dysfunctions such as cerebral palsy, Down syndrome, seizures, or developmental delays should also be referred to an eye doctor. If you need to screen these children because the screening is required for Form 3300 or a special ed evaluation, do go ahead and perform the screening to meet those requirements, but still make the referral to an eye doctor. Now, I've mentioned ABCs several times. ABCs refer to appearance, behavior, and complaints, and these are referable signs that a nurse may observe or that parents or teachers may have noted. When we talk about appearance, we're talking about looking at the child's eyes, inspecting the child's eyes for signs and symptoms. Behavior just refers to the child's stance or vision-related habits, or just things we notice about the child's behavior or manner that may indicate a problem. Complaints are things that the child actually tells us that indicate discomfort or illness. Now, young children especially may not sense or complain about visual discomfort or difficulties just because they don't know that that they should, or that they're anything that the parent needs to know about. Observation of signs and symptoms is sufficient cause to refer a child alone, but especially when you're doing mass screenings, you want to go ahead and complete the other screening tests, because the screening test may confirm what it is you've observed, and that makes your referral to the eye doctor much stronger. So what are some of the appearance signs you might observe? You might notice that a child's eyes cross or turn out or drift. The eyes may be red or watery. You might notice that eyelids are encrusted or swollen or red. Maybe the eyelid droops. You might notice that a child has a sty on the eyelid or conjunctivitis. And I want to stop here. It is okay to screen a child who has a sty. Just be aware that the child is going to be a little sensitive because that eyelid is uncomfortable. On the other hand, if a child has conjunctivitis, as you know, that can be highly contagious. So you do not want to screen the child who has conjunctivitis today. In fact, you probably want to get the child out of the school as quickly as possible. If you need to confer with someone else about whether or not this child, in fact, does seem to have conjunctivitis, do that, but don't do the screening. And if you've touched the child or the child has touched any of your screening tools, be sure to clean those and wash your hands before you proceed with any other screening. Other appearance signs you may observe are eyes that are obviously of different sizes, eyes that are constantly in motion, and eyes that look very cloudy. Maybe one eye is much cloudier than the other, or maybe both eyes look cloudy. You might also notice a pupil that appears to be white rather than black, which is the way most pupils generally look. The behavior signs you may observe are things that we all do when we can't see very well. The child may become rigid while looking at distant objects, such as the eye chart. The child may tilt his head to one side or squint and frown. The child might blink excessively, or maybe the child rarely blinks at all. The child might thrust his head forward while looking at distant objects. He may close one eye or cover an eye frequently. The child might rub his eyes excessively or appear to be unusually awkward. And the child might bring objects close to his eyes. Other behavior signs include the moving of the child's head close to the desk or to objects when reading, especially when reading. The child might be abnormally sensitive to light or have poor hand-eye coordination. Maybe the child uses his finger to keep his place while reading. The child might have a short attention span or reverse letters and words. The child might also just be irritable or restless during sustained near work or visual concentration. Some of these signs and symptoms you may observe during the course of a screening. Some are more likely to be noted by a teacher, and maybe the teacher will tell you about those before the screening. The complaint signs that you might hear about are that the child has headaches or nausea or dizziness. The child might complain about letters blurring or lines running together or jumping. The child might say that his eyes itch or burn or ache, or maybe complain about blurred vision, especially after close work. Maybe the child just complains that he can't see well or can't see the board, or maybe the child complains about seeing double. Again, young children may not verbalize these complaints because they don't know that these things are unusual and shouldn't be happening. They don't know the way vision should be. It's okay to refer based on observation and signs and symptoms alone, but use your common sense. Talk to the teacher. Does the child have allergies that are especially bad this week? Has he been sick? Is he on any medication that might affect his vision? And do go ahead and proceed with the screening test, because they are likely to confirm and strengthen your referral and may be required for Form 3300. In this section of the training, we're going to talk about distance visual acuity screening for children ages 3 through 5. Most of you who will need to know about this screening are screening children in pre-K and kindergarten. Visual acuity is an assessment of the eye's ability to distinguish object details and shape using the smallest identifiable object that can be seen at a specified distance. Research shows that distance visual acuity testing is the single best index for determining the existence of visual problems in children. We usually determine visual acuity by having a person read a standardized visual stimulus, such as an eye chart, at a distance of 10 or 20 feet. We usually talk about visual acuity in terms of a fraction. So what does the fraction mean? The number on the top refers to the distance at which the child is standing from the visual stimulus. The number on the bottom refers to the distance at which a person with normal vision can see the specified stimulus. So, on the eye chart, when you look at the 20/20 line, a person who has 20/20 vision can read that line from a distance of 20 feet. When you look at the line on the eye chart that says 20/60, a person with normal vision can see that line from a distance of 60 feet. But a person whose vision is 20/60 can only see that line from 20 feet. So a person whose vision is 20/60 sees as if 3 times further from the chart than a child with normal vision. We do recommend that the vision screening that you do be done with a chart that's been calibrated for screening at a distance of 10 feet. It's easier to manage distractions at that distance, easier to hold the child's attention, and it's easier to find a space of 10 feet in order to conduct the test rather than 20 feet. You will notice that the equivalent 20-foot markings are printed on the edge of 10-foot charts. This is a Leah Symbols distance vision chart. This chart was designed especially for screening children ages 3 through 5. It's easy to administer to young children because they don't have to know the alphabet. They don't have to be able to point in the same direction as the E. And all they really need to do is just tell us what they want to call these pictures. This is not going to be a shapes test. The child is going to tell us his name for each of the optotypes. The other good thing about this test is that the shapes blur equally, and they're equally difficult to identify. You may notice that as you look at the smaller lines on the chart, when you're beginning to have trouble distinguishing them, they do look like each other. So closer to the bottom, you may think that all the shapes look like circles. And when we're screening children, especially young children, that's just fine because we don't want them to sense any failure by giving us the wrong names for the shapes. And we're not going to let on if they do. Some of you may have or may have seen a wider version of this chart, and that chart is fine as well. So if you have that other chart, you may continue screening with it. Again, notice that this chart is calibrated for screening at a distance of 10 feet. To set up your screening area for screening with the Leah Symbols chart, you're going to place the chart on an uncluttered, well-lighted wall. You will place the 20/40 line on the wall so that it's 42 inches from the floor. The important thing to know is that we're placing the pass line on the eye chart so that it's at the average eye level of preschool age children. Next, you're going to mark the place where the child is going to stand for the testing. You're going to place the heels of the happy feet so that the heels are 10 feet from the eye chart and centered in front of the chart. If you don't have happy feet, simply place a piece of masking tape so that the tape is 10 feet from the eye chart. When you're selecting the location for your chart, do consider the lighting. It's best if you can get directly under fluorescent light that happens to be close to the wall. And be aware of windows that are in the room and traffic patterns. If you have sun shining directly into the room, you obviously want the child facing away from the sun instead of trying to stare directly into it. But be aware of glare or stripes that may be caused by shutters or shades that are on the windows. And consider traffic flow. It's going to be best if the child's back is to traffic so that he won't be distracted every time somebody walks into the room or walks by the door. You will want to place a chair next to the eye chart. The screener is going to actually sit by the chart and point to the shapes. The screener will need a pointer, a pen, a clipboard is helpful, whatever documentation forms are being used. Place occluders the key card, and a trash basket by the Happy Feet. This is a visual of what the setup might look like. You're going to have the eye chart on a wall. 10 feet away from the eye chart, you will have the Happy Feet with the heels on the Happy Feet such that they're 10 feet from the eye chart. And the eye chart is going to be placed so that the 20/40 line is 42 inches from the floor. That other little line in the middle where it says 20 inches from heels of Happy Feet will be used for the random.e test, and we're going to talk about that a little bit later. To begin the screening, remember all those things we talked about that you need to confirm up front, especially the child's age. Also, if the child wears prescription glasses, you'll screen the child with the glasses if he has them, because we want to make sure that the glasses are doing what they should be doing. You'll position the child on the Happy Feet so that the child's heels line up with the heels of the Happy Feet. I want to emphasize that the heels are the important thing. We want the heels to be lined up with the heels on the Happy Feet, or the child's heels should be on the masking tape, not their toes, not the arch of the foot, not any other part in between, but their heels. If the child happens to be in a wheelchair, you should roll the wheelchair over the Happy Feet so that the back of the child's head is lined up with the heels on the Happy Feet. The first thing you're going to do is practice with both eyes open and uncovered by pointing to each shape on the top line of the eye chart. We're not only trying to find out what the child is going to call the shapes, but we just want to make sure that the child understands what it is we want to do, and we want to make sure that we know the child's names for all of the different optotypes or symbols. Note that if the child can't or won't speak, or if the child doesn't know the letters, or if the child doesn't speak English, the child can point to matching pictures on the key card. Note that when you do hold the pointer underneath a shape, you should hold the pointer vertically directly beneath the shape you want the child to name, leaving a little white space between the end of the pointer and the symbol. Try not to touch the symbol that you're asking the child to name. As you're pointing, give the child positive verbal reinforcement for each response. So every time the child names a shape, just say, good, great, wonderful, perfect, good job. If he gives you an incorrect response, just say, okay. Use the same tone of voice and keep on moving at the same speed. Most children think the word okay is pretty positive, so they're not going to know that they've given you a wrong answer. To begin the actual screening, once you've done the practice, have the helper cover the child's left eye so that we can screen the right eye first. It's a good idea to get in the habit of screening always the right eye first and then the left eye. For younger children, it's best that an adult hold the occluder because especially younger children are going to tend to pull the cup away, especially when they can't see. So have the helper cover the child's left eye so that you can test the right eye. Then starting on the 20/80 line, point to the outermost shape on the chart, ask the child to name that shape, and then continue down the outside edge of the chart until you get to the pass line. So what is the pass line? For children age 3, the pass line is 20/50, and you generally won't need to know that. But for children ages 4 and 5, the pass line is the 20/40 line. So you're going to point down the outside edge of the chart until you get to the 20/40 line. When you get to the 20/40 line, you're going to start pointing across that line. In order to pass a line on the chart, the child must identify more than half of the shapes correctly. Generally, that's going to be 3 shapes on each line. So you will proceed down the chart in a zigzag or S-shaped fashion to the smallest child the child can read. To the smallest line the child can read. You'll constantly monitor the child for proper occlusion, for the position of the child's feet, and for signs and symptoms of vision problems. Note that especially with pre-K kids, they tend to be pretty wiggly, so you really need to make sure that they're standing at the 10-foot distance. Some people who are going to be helping with the screening frankly, do a better job of holding the occluder than others. So you need to watch the child frequently to make sure the occluder is actually over the child's eye and not over his nose or in the middle of his forehead. Likewise, this is a great time to observe for signs and symptoms of vision problems. You may notice that the child is leaning forward or tilting his head, or that he's blinking excessively, or that he's really straining. Sometimes you'll notice that the child is trying to get away from the occluder, and you need to make a judgment. Is the child trying to get away from the occluder because it's uncomfortable or it's in his eye, or is he trying to get away from the occluder because he really can't see and he needs that other eye in order to see clearly? The acuity is the lowest line on which the child successfully identifies three shapes. When you get to a line and the child gets three shapes wrong, you just stop at that point, and the line above, which is the lowest line on which the child had three shapes correct, is the child's acuity. If the child can't read the 20/40 line, then what do? You're going to move up the outside edge of the chart until the child can correctly identify a shape, and then you move across that line and on down the chart as before. So don't panic. Sometimes you may have to go all the way back to the top of the chart before the child can read all the way across the line, but then he might read down to the 20/25 line. So don't panic and drop your jaw and gasp and look at the person you're screening with and say, oh my gosh, the child is blind. Just calmly proceed to the top of the chart and work your way down again. Note that if the child is using the key card to point to matching pictures, you do need to glance at the child every time you point to a new shape to confirm that the child is actually looking at the chart, because the child can just stare down at the key card and point to pictures and get a lot of the shapes correct without ever looking at the chart. When you're using this procedure to complete this screening, it'll be best if your helper just tells you what shape the child is pointing to, and then you know whether to proceed with the screening or to stop. When you do determine the child's acuity, it is important that you determine what the acuity is and record the acuity immediately before you look away from the chart. Once you've completed screening the right eye, you need to rescreen the left eye using the same procedures. So now you're going to cover the right eye, which leaves the left eye open. If you can remember, start from the opposite side of the 20/80 line and then move down the outside edge of the chart again to the pass line. Once you get to the pass line, move across that line as soon as the child gets three shapes correct. Move down to the end of the next line and proceed. Once the child gets three shapes incorrect, again, stop, record the acuity of the left eye, and record any observations that you may have about the child. These observations will be helpful later on, especially if you need to refer the child and talk to the parent about what you observed. This chart outlines the passing line for children different ages. For children who are 3 years old, the passing or critical line is the 20/50 line. For children ages 4 to 5, the passing line is 20. In order to pass the distance acuity test, a 3-year-old has to have an acuity of 20/50 or better in both eyes with no two-line difference. 4 and 5-year-olds need to have acuity of 20/40 or better in both eyes with no two-line difference. So what is a two-line difference? A two-line difference exists when a child sees at least 2 lines better with one eye than the other. So you can see these examples. For a 3-year-old, an acuity of 20/50 in one eye and 20/30 in the other is a two-line difference, or 20/50 and anything below 20/30. For 4 and 5-year-olds, 20/40 and 20/20 is a two-line difference, or again 20/40 and anything below 20/20. If the two lines are next to each other, if the child's acuity in one eye is the line just above the acuity in the other eye, there is no two-line difference. That's okay as long as the child is within the passing range. But it's when there's at least one line in between the two scores that you have a two-line difference and the child needs to be rescreened. Note that some charts have an acuity marking of 20/32 instead of 20/30, and that's okay. Both charts are just fine. It's generally going to be easier for you to look at a chart to figure out whether or not there's a two-line difference. Most of you will probably never memorize the markings on the eye chart, and so you will have to look at the chart itself to figure out whether or not there's a two-line difference. You need to rescreen a child if, for example, the child is 3 years old and the acuity is 20/60 or worse in one or both eyes, or if the acuity is 20/50 or better and there exists a two-line difference. For 4 and 5-year-olds, if the acuity is 20/50 or worse in one or both eyes, or if the acuity is 20/40 or better, but there is a two-line difference, then the child needs to be rescreened. When you rescreen the child, if these situations still exist, then you will refer the child to an eye doctor. You should always rescreen a child before referring. About 50% of the children who fail the initial screening pass when rescreened, and we don't want to make unnecessary referrals. It's a good idea to wait a couple of weeks if you can before rescreening, but if you must rescreen the same day, do allow the child some time to rest before retesting. Note that Titmus and Optec screening machines are not appropriate for screening young children, and they're not the preferred method for screening older children. The difficulty with these machines is that they don't allow for observation of signs and symptoms, and the child can easily turn his head and actually be using both eyes without that being detected by the screener. So it's really best not to screen, especially younger children, with the Titmus or Optec screening machine. Some of you may be familiar with some of the new photo screening devices that have come on the market in the last several years, and some of you may be fortunate enough to have access to them. But these machines, plus Optics, SureSight, Spot, are all useful in screening 3-year-olds or special needs kids. You may not have access to those in the school system, but several of the public health departments throughout the state do have some of these devices. So you may see some screenings that have actually been done by them using these devices. In this section, we're going to talk about distance visual acuity screening for children 6 and older. Visual acuity is the assessment of the eye's ability to distinguish object details and shape using the smallest identifiable object that can be seen at a specified distance. Basically, it's just the ability to be able to see fine visual detail. Research shows that a distance visual acuity test is the single best index for determining the existence of visual problems in children. We usually determine visual acuity by having the child stand at a certain distance, usually 10 or 20 feet, from a standardized visual stimulus, such as an eye chart. We refer to the measurement in terms of a fraction. You've heard people say that they have 20/20 vision, or that their vision is 20/200. So what does that fraction mean? The number on the top refers to the distance at which the person is standing or seated from the eye chart. The number on the bottom refers to the distance at which the normal eye can read that particular line. A person with 20/20 vision can stand 20 feet away and see the line on the acuity chart that's marked 20. A person with 20/20 vision can stand 200 feet away from the eye chart and see the line at the top marked 200. On the other hand, if a person has 20/200 vision, they can only see the 200 line from a distance of 20 feet. The larger the number on the bottom, the worse the person's vision is. In the example shown in this slide, a child who has 20/60 vision sees as if he's 3 times further away from the chart than a child with 20/20 vision. This is an HOTV distance chart, which is a chart that we recommend for screening older children. It has several different letters. It's definitely more interesting than all E's, and it doesn't rely on a sense of direction. Some of you may have Snellen charts that you've had for years. It is acceptable for you to keep using the Snellen chart. However, if you need to replace or buy new distance vision charts, it's recommended that you purchase the HOTV chart. Now let's talk about the setup of the screening area for the HOTV or Snellen distance vision chart. You want to place the chart on an uncluttered, well-lighted wall. If you can find a blank space on the wall that's close to a fluorescent light, the lighting should be good there. But think about the traffic pattern in the room, other distractions that may be going on, as well as light coming in from windows. It's generally best to have the child's back to the door or to the traffic and congestion that's going on in or beside the room, and also facing away from the sunlight. You don't want the child to have to be looking directly into the sun. Be aware of any glare or stripes on the wall that are being created by blinds that are at the windows as well. The chart should be placed so that the pass line, which is the 20/30 line, is at the average eye level of the children being screened. This means that if you're doing a mass screening, for instance, if you're screening third graders and fifth graders, you might need to raise the chart when you get to the fifth graders because they're probably going to be considerably taller. Place a strip of masking tape on the floor 10 feet from the chart and centered in front of the chart. This is where the child is going to stand. Place the pointer, a pen, and documentation forms close to the chart. Then place the occluders, the key card, and a trash basket by the tape mark on the floor. This is a simple visual of what the screening setup looks like. So you've got the chart on the wall with the 20/30 line hanging just based on the child's eye level, depending on the child you're screening. 10 feet away and directly centered behind the chart is a piece of tape, and the child is going to stand with his heels on the tape. If you're screening children through third grade who need the random.e test, that middle mark at 20 inches from the heels will be used for the random.e test, and we'll talk about that a little bit later. Most of the children that you're screening are going to be old enough such that the pass line for them is going to be the 20/30 line. Remember, the pass line is 20/30 for children ages 6 and older. If you happen to be screening a kindergarten class, however, you may have some children who are 5 and some are 6. So do make sure that you know the ages of the children you're screening. Remember that you also need to know whether or not the child has prescription glasses. The child should be screened with his or her prescription glasses if there are any. Position the child so that the child's heels are 10 feet from the chart. Remember, we're talking about the heels again. The heels should be on that masking tape that marks the 10-foot line, not the toes or some other part of the foot. If the child happens to be in a wheelchair, then the wheelchair should be rolled over the 10-foot tape so that the back of the child's head is lined up over that piece of tape. To begin the screening, you're going to practice on the top 2 lines of the chart, actually, with both eyes open and uncovered. You want to point to each of the letters and make sure that the child knows the letters and that you understand what the child is going to say and that the child understands what it is you're expecting of him. Reinforce the child with some type of verbal reinforcement for each response. So just say good, great, wonderful if they give you the correct answer. Just say okay if they give you an incorrect answer. To begin the screening, once you've practiced with both eyes open and uncovered, instruct the child to cover the left eye with his hand or with an occluder. You're going to be screening the right eye first, so the left eye is covered. Starting on the 20/80 line, ask the child to read down the outside edge of the chart to the pass line, which in most cases is going to be the 20/30 line. Once the child gets to the 20-30 line, he should read across the line and continue reading down the chart as far as he can to the smallest line he can successfully read. In order to pass the line on the chart, the child must read more than half of the letters correctly. The acuity is the lowest line that the child successfully completes. Once the child completes the screening with the right eye, then you should record the result immediately. Now you're going to screen the left eye, which means the child should cover his right eye. If you can get him to start on the opposite side of the chart, that would be great. He should come down the outside edge of the chart from the 20-80 line down to the 20-30 pass line, then read across each line of the chart as far down as he can read from there. As soon as he finishes with the left eye, record the acuity, and then record any observations that you've observed. Older children should be able to hold the occluder themselves or use their hand as an occluder, but an adult may need to help younger children, so be expecting to do that, especially maybe with your kindergarteners and first and or second graders. Older children should also be able to read the chart with the screener pointing only to the pass line or cueing the child where to read. You generally won't have to point to every single letter on the chart for older children. But you do need to monitor constantly for proper occlusion, for the position of the child's feet, and for signs and symptoms of vision problems. Especially since you don't have someone standing right beside the child holding the occluder, you really do need to make sure that the child is not removing the occluder from his eye as you're testing. The critical or passing line for children 6 and older on the HOTV or Snellen chart is the 20-30 line. While the passing line is the same for all children 6 and older, notice that there are two sets of pass criteria. For children ages 6 through 9, there is still some risk that the child might be at risk for developing amblyopia, so we're looking for a significant difference in vision between the two eyes. Consequently, the pass criteria for children ages 6 to 9 are that the child's acuity must be 20-30 or better in both eyes, and there can be no two-line difference. For children 10 and older, the pass criteria is simply that the child's acuity must be 20-30 or better in both eyes. A two-line difference means that a child can see 2 or more lines better with one eye than the other. To decide whether or not a child needs to be referred, you obviously look at the pass criteria, which is 20-30. For children ages 6 to 9, then, if the acuity is worse than 20-30, if it's 20-40 or above, or if the acuity is 20-30 or better in both eyes and there is a two-line difference, you're going to rescreen the child. For children 10 and older, if the acuity is 20-40 or worse in one or both eyes, you're going to make the referral, but you don't need to worry about a two-line difference. Once you have rescreened the child, you will make a referral if the child's results are the same as these. That is, for a 6 to 9-year-old, the acuity is 20-40 or worse in one or both eyes, or it's better but there's a two-line difference. Or for 10-year-olds, the acuity is 20-40 or worse in one or both eyes. Let me just explain the two-line difference again, if you're not familiar with this term. The two-line difference means that the child sees 2 or more lines better with one eye than the other. That means when you're looking at the results, there's one line in between the two different scores. You're probably going to have to look at the acuity chart in order to figure this out. And notice that on some charts, there may not be enough lines below 20-30 to make it possible to identify a two-line difference. It is important that you always rescreen before referring, because many children pass the rescreening test. Do try to rescreen within 2 to 3 weeks. If necessary, it is acceptable to rescreen the same day, but do let the child rest before you do so. And do notice that some charts have 2032 and 2063 acuities instead of 20/30 and 20/60. Both are acceptable. Some of you may be using Titmus machines or Optec machines in order to do vision screening. These machines are not the preferred method for screening older children simply because they don't allow for observation of signs and symptoms of vision problems, and it's also easy for the child to tilt his head slightly and be using both eyes. However, if you do use the Titmus or the Optec for screening older kids, you will use the same pass-fail criteria as you would with a chart. But it is important that you sit facing the child and that you monitor the child's head you monitor the child for proper occlusion. Now we're going to talk about stereopsis screening. Stereopsis refers to visual perception of three-dimensional space resulting from the blending of images from the eye. Remember, at the beginning of the training, we talked about how vision works, and we talked about the fact that each eye is receiving an image that's being transmitted by the optic nerve to the brain. And it's when the brain merges these two images that we are able to see things in 3D, or we can see with depth perception. A stereopsis test helps identify those children whose eyes are not working together as they should. And these are children who are at the greatest risk for amblyopia, or loss of vision in one eye. The test we're going to use for stereopsis is called the Random.E test kit. And this test kit has a pair of 3D glasses, and it has 3 cards. One is a model card that has a matte finish, and it has an E on it that's literally 3-dimensional. It's a raised E. The other 2 cards are the actual test cards, and they're shiny, and one is called Stereo Blank, and the other is called the raised E card. The Stereo Blank has a bunch of dots on it that don't form any shape. It just looks like a blank gray card. The raised E card has a bunch of dots on it, but on this particular card, the dots form the shape of a 3-dimensional looking E. Remember that when we were setting up the acuity charts, there was an extra piece of tape on the floor, and that was for the Random.E test. The Random.E test can be conducted at one of 3 places. If you are the screener sitting at the chart, you could bring children to you to conduct the Random.E test, or you can leave the child standing 10 feet from the eye chart and you can move to the child, or you could have the Random.E set up in a totally different place in the room, especially if there's a second screener who can do that test. But basically what you need to know is that in order to conduct the test, you're going to have 2 pieces of tape on the floor. You will be holding the test cards over one piece of tape. The child will be standing facing you, and the child's heels are going to be on the other piece of tape. It's important before you determine the test location that you check the lighting. So what you need to do is to put on the 3D glasses yourself, kneel to the child's eye level, and then hold up the raised E card to make sure that the lighting is good and that the E can easily be seen. If you can't see the E very well, then you need to find a different place to do the test. So let's talk about the tape again. If you're going to leave the child on the happy feet, then what you're going to do is put one piece of tape on the floor so that it is 20 inches from the heels of the happy feet. If you're going to bring the child up to you by the eye chart, then you need to put one piece of tape on the floor at your feet and another piece of tape 20 inches away, further away. If you're leaving the child in position on the happy feet, then you will hold the test cards over that piece of masking tape 20 inches away. Likewise, if you're bringing the child to you at the chart, you will hold the Random.E cards over the piece of tape closest to you. The child will stand with his heels on the other piece of masking tape between the 2 pieces of masking tape. and everybody will be in the right position. When you're sitting in a chair doing the screening, you will be pretty much at the child's eye level, so you should be easily able to look at the child's eyes. You will need to place the Random.E test kit close by, and you will also need antiseptic wipes when you're doing this test. To begin the test, you're going to position the child so that his heels are on the tape or his heels are lined up with the heels on the happy feet. The first thing you're going to do is present the Model E card. You just need to show the card to the child to make sure that he sees the E and understands what he's looking for. Lighting is important even for displaying the Model E card, so you may have to tilt it slightly so that the child can see it better. And if the child still says he doesn't see the letter, then you can flip the card over so that he can see the E in black and white. This is not a test of whether or not the child knows the letter E, there's really no need to spend a lot of time waiting for the child to correctly identify this as an E. The main thing is that the child sees it. He might call it an E or a 3 or an M or a W or just lines. It doesn't matter as long as he sees it. Once the child has seen the E, you're going to position the 3D glasses on the child. If the child wears prescription glasses, then you should put the 3D glasses over the prescription glasses. And you should always be the one to handle the 3D glasses. One other thing I'd like to note is this test happens to be conducted at near vision. If you have a student who wears glasses for reading only, he should wear his reading glasses. Most children at this age don't wear just reading glasses or have bifocals, but if you happen to run across a child that does, then you need to make sure they're using the correct reading portion of their glasses or they're wearing their reading glasses. If the child's glasses are for distance only, they should not be worn for this test. So now that you have the glasses on the child, you're going to begin the test. You need to make sure that you are holding the two cards that say stereo blank and raised E, and the cards should be held in the upright position. You should actually see the word stereo blank and raised E yourself, and the child is going to be looking at the other side of the cards. You should present the cards so that they're parallel to each other, parallel to the child's face, and fairly close to each other. They should be at the child's eye level. The child should not have to look up or down in order to look at the cards. You should be holding the cards so that they're over the piece of tape at your feet that's marking the 20-inch distance. It's best when you hold the cards that you hold them on the sides, kind of pinch between your thumb and your forefinger, rather than cupping the cards such that the thumb is on the bottom and your other four fingers on the top. If you've got the other four fingers on the top of the card, then you may be casting a shadow on the card and making it difficult for the child to see the E. Once you present the two cards, you should ask the child to point to the card that has the E. Hopefully the child will point to the E, at which point you're going to put the cards behind your back and then present them again so that the E is in a different place. You don't actually have to switch the cards in your hands every single time you move them behind your back, because you can actually hold the E in 3 different places without making that switch. So if you're challenged at switching the cards behind your back without holding them up again in the right direction, then you don't have to do it quite so often. You need to repeat the presentation of the cards until the child sees the E 4 times in a row. If the child doesn't see the E consistently, or maybe he sees it a couple of times and then the next time he misses it, stop and make sure that the child understands what it is that you want him to do and which card it is that you want him to point to. So a couple of tricks I use are to just put the Model E card on the desk so that the child can see it, or even on my knee. And if the child misses the E on one of the presentations, I point to the Model E that's on my lap and say, well, this is what the E looks like. Which one of these other pictures matches? Or this is what the E looks like. Do you see it on one of these cards? And then I try the test a couple of times. If that doesn't work, Then I play the game with the Model E card and a blank index card. I usually keep a blank card inside my test box. So I'll hold up the Model E and I'll hold up the blank card and I'll say, which one of these has an E? Trust me, 90% of the time the child points to the blank card, which explains the problem. So then you just say, well, this is a blank card. I want you to point to this card that has the E on it, and continue playing the game a few times until the child is consistently pointing to the E on the model card. Then put the model card and blank card down and switch to the real test cards, the ones that say stereo blank and raised E. Start playing the game again, and hopefully at this point the child will be consistently pointing to the E card, and that will take care of the problem. Do also watch the child's eyes. You should be able to see through the Random.E glasses. Make sure that the child is actually looking at the test cards. Sometimes the child doesn't even look. The child may decide which card he's going to point to before you even have them fully raised, in which case you just need to slow the child down. You may want to hold up one card at a time and say, look at this card. You hold up the second card and say, look at this card. Now, where do you see the E? The important thing is that the child understand the test and that he's really looking at the card. Very few children should fail this test, and we don't want to be sending parents to the eye doctor too often just because the child doesn't understand this particular test. At the end of the game or the test, it is important to remember that you need to clean the frames only of the Random.E glasses with disinfectant. I want to highlight the fact that you should clean the frames only. The lenses don't take real well to the antiseptic or alcohol swabs. I think that's it for the Random.E test. Now let's talk about interpreting the results. The child passes the Random.E test if he sees the E 4 times in a row. You need to rescreen the child if he could not see the E at all in at least 6 presentations, or if he couldn't see the E 4 times in a row. Remembering, though, that if he's not seeing the E consistently or at all, you're trying to think of every different way you can possibly explain this test before you give up. If you do need to refer the child, as with other tests, it's a good idea to wait. And then when you rescreen, the criteria are the same. The child should be referred if he couldn't see the E at all in at least 6 attempts, or if he couldn't see the E 4 times in a row. If you have the luxury of having another trained screener in your school, you might ask the other screener to administer the test, because sometimes the child just understands another person's description a little better or responds to the other person and may very easily pass the test quickly when someone else is administering it. And again, do make sure that the lighting is good. If all of a sudden you have a bunch of children failing this test, maybe you need to stop and put on the glasses and check the light before you continue. The color vision test is actually a test to help identify whether or not a child has a discrepancy in the ability to recognize differences in color. It's not really a color blindness test. We're looking for a difficulty in recognizing colors, but not total blindness. There are several acceptable tests for color vision testing. One is Color Vision Testing Made Easy. Another is Ishihara Color Plates, and another is the Hardy-Rand Ritter test. If you have any of these tests in your school, it's fine to go ahead and use whichever one you have. For purposes of this training, we're going to talk about the Color Vision Testing Made Easy by Wagner. Color vision testing should be conducted in a room that has fluorescent or natural light, and it's important to remember that you should not touch or let children touch the color plates on this test, as that will degrade the quality of the plates. As with all the other tests, if a child wears prescription glasses, then the prescription glasses should be worn for the color vision test. The Color Vision Testing Made Easy test consists of a book. It's a 3-ring binder that has a demo card and 9 test cards. The background colors of the different test cards vary, as do the colors of the shapes on the card. Each of the cards contains some combination of a circle, a square, or a star. In order to administer the test, you should measure a distance of 30 inches from the child's eyes to the color book. You might want to do this particular test sitting across a table from the child. Hold the color book so that the test cards are perpendicular to the child's line of sight. If you are testing younger children, they may actually just use a cotton swab or a paintbrush to outline the shapes on the cards. Older children should just be able to tell you what shapes they're seeing on the child. And remember, generally you're going to administer this test only once to each child. You should generally wait until the child is 6 to administer the test. But if there are younger children in your school about whom there are concerns with regards to color, it is fine to go ahead and use this test on younger children. So to begin the test, you're going to instruct the child to outline or name the shape on the demo card. Then you're going to proceed with presenting cards 1 through 9. Older children should just name each of the shapes on the cards. Younger children just need to outline the circle on the cards. Allow only 3 seconds for each response. The child shouldn't be allowed to stare at the color plates for long periods of time. And just kind of as a check to make sure that the child understands the test, every child should actually be able to identify the circle on cards 1, 3, and 5. So if the child doesn't correctly identify the circle on those 3 cards, he doesn't understand the game and perhaps the instructions should be reviewed. In order to pass the test on the initial screening, the child must correctly identify or name the shapes on 8 out of 9 of the test cards. If the child correctly identifies 7 or fewer shapes, or excuse me, if the child correctly identifies the shapes on 7 or fewer cards, then the child needs to be rescreened. When the child is rescreened, the child must see the shapes correctly on 9 out of 9 cards and fails the test if he correctly identifies the shapes on fewer than 9 cards. Color vision testing needs to be done only once. A child either has color deficiency or doesn't. It doesn't get worse and it doesn't go away. Likewise, color deficiency can't be corrected. So a child may be referred to an eye doctor just for identification of the specific color deficiency or the degree, but there is no treatment for color vision deficiency. Parents and teachers should be informed that a child is having problems identifying colors so that they can make accommodations for those deficiencies. If you're completing vision screening for the Form 3300 and the child fails the color vision test, do not mark the Form 3300 refer for further examination if this is the only test the child fails. So let me say that differently. For purposes of Form 3300, if the only test the child fails is color vision, then the child passes the exam, the screening for these purposes, and should not be referred to an eye doctor. Near vision testing should be completed only for those children who are in the RTI process or are being evaluated for special ed entry. It should not be included as part of mass screening. In fact, Prevent Blindness generally does not even recommend near vision screening, primarily because the screening tools are not precise, and especially if they're not done at correct distances, can yield incorrect results. Especially for younger children, Past results may be incorrect because children can generally accommodate at near distance for a short period of time, and they may pass the test even though their near vision isn't great. Usually a failed result is valid if the test is conducted at the correct distance. Special needs children generally have more vision problems than the population at large, and because they're special needs, they may have other difficulties that make it even more difficult to administer screening to them than general population. So for this reason, an eye exam is preferable. Primary considerations for accurate near vision screening are that you maintain the correct distance between the child's eyes and the eye chart. You have very good lighting. Trust me, in order to see these little optotypes, you need good lighting. And especially for younger children, you may need a helper in order to help maintain the correct distance. I will tell you that it's also very helpful if the screener has good near vision. The near vision test is conducted with the Leah Symbols Near Vision card. This card, it comes with a measuring cord attached to it, which helps maintain the proper distance of 16 inches. It has 4 flashcards, each one showing one of the symbols that's on the chart, and it also has an answer key. Other tools that you'll need in order to complete the test include some type of occluder or occluder glasses. You might use disposable eye patches, an index card, a plastic occluder, but I do encourage you to think about using occluder glasses, just because I found that it's helpful to attach a small rubber band to the glasses, and that helps you maintain the correct distance from the eye chart. You'll also need a pointer or a cover card, antiseptic wipes if you're using disposable occluders or occluder glasses, as well as masking tape. To set up the screening area, tape the near vision card to a well-lighted door or other flat surface at the child's eye level, with the knob hanging off the edge of the surface so that the card is flat. If you're using occluder or plano glasses, or if the child has prescription reading glasses, place the rubber band at the end of the cord that will be held by the child's eyes, and then put the glasses on the child, making sure that that little knob is right beside the child's eye. Position the student at a distance so that the cord between the chart and the glasses is taut, and again, so that that knob attached to the glasses is by the child's eye. A helper may be helpful, especially with younger children, to help maintain the correct distance. You want to make sure that the whole time you're administering the test, that cord is taut. If the child wears prescription reading glasses, you may either place an occluder over the prescription glasses. You could put a patch over the eye but under the prescription glasses, or you can put a plastic occluder over the prescription glasses. To begin the screening, you're going to practice with both eyes open and uncovered on the very bottom line on the eye chart. You're going to ask the child to name the symbols, or let the child point to the matching flashcard, match the symbol that you're pointing to the flashcard. Once the child gets the hang of either naming the shapes or pointing to the matching pictures, you're going to start the screening. And as with a distance test, you're going to screen the right eye first, which means you need to occlude the left eye. To screen the right eye, you're going to use the lower right section of the Leah Symbols Near Vision card. Ask the child to name the first symbol on the outside edge of that right section, and you'll ask the child to continue reading the shapes down the outside edge of the chart. Once the child hesitates at a given symbol, go back to the line above and ask the child to start reading across that line. As you're doing this test, if the child doesn't know the shapes, he can just point to the large optotypes at the very bottom of the chart, or to the flashcards. It's probably a little bit easier for you to visualize what I'm talking about if you look at the chart quickly. You see the bottom line that just has the 4 large shapes. That's where you're going to practice. Then to test the right eye, you're going to use that lower right section, but the child may point to that big line at the bottom if he needs to for matching pictures. As you probably have guessed, when you screen the left eye, you're going to use that lower left section to conduct testing for the left eye. As you're proceeding down the chart, you may find that it's helpful to hold a cover card above the line that the child is reading. So this can just be a blank index card, or you could even use one of the small flashcards to cover the line above the one that you want the child to read. You may also, if you prefer, point briefly to the shapes. But to be quite honest, I've found that the cover card's a little bit easier because as the shapes get smaller and smaller, the pointer is just not small enough to keep up with the size of the shapes. And if your vision's not all that great, you may find it helpful to use the answer key to read along with the child if you can't read the shapes yourself. As with distance acuity screening, the child's acuity is the smallest line on which the child correctly reads 3 out of the 5 shapes. The acuity markings are on the far edge of the card, as with other charts. And just remember, as soon as you finish screening the right eye, you need to record that result. And then you'll repeat the procedure with the left eye, but this time you're going to use the lower left section of the near vision card. And again, you'll occlude the right eye, use the lower left section of the card, ask the child to read down the outside edge of the chart until he has difficulty. Then you're going to back up the line, and at that point you ask the child to start reading across the line as far down as he can read. Correct distance is crucial for getting accurate results on the near vision test. When you're doing a distance test at 10 feet, if you're off an inch or so, it's not so crucial, but when the distance is only 16 inches, if you're off 1 or 2 inches, percentage-wise, that's a big difference and can result in an incorrect result. For children ages 3 to 5, the passing line is 20/40. For children ages 6 and older, the pass line is 20/32. Therefore, in order to pass the near vision test, a child who is aged 3 through 5 must have an acuity of 20/40 or better in each eye. A child who is 6 or older must have an acuity of 20/32 or better in each eye. I would like to mention that generally monocular screening is all that's necessary in order to complete the near vision test. However, some school districts require that testing be done with both eyes together. And if that's the case in your school district, then go ahead and complete the screening with both eyes open, but you'll use the middle section, the larger section of the card to complete that binocular screening. The pass lines are the same if you're administering binocular screening as for monocular screening, so you'll use these same guidelines for both. You will rescreen any 3 to 5-year-old whose acuity is 20/50 or worse in either eye. You'll rescreen 6-year-olds and older children if their acuity is 20/40 or worse. When you do the rescreening, if the results are the same, you will then refer the child. So you will refer the child if the acuity is 20/50 or worse for a 3 to 5-year-old, or if the acuity is 20 or 40 or worse in a 6-year-old or older. As with other vision tests, you will rescreen a child who fails the near vision test. Again, if you can wait a couple of weeks to do that, that's great. But if you're meeting deadlines for testing, then just be sure to give the child some time to rest before you rescreen. In summary, for any of the tests that you're conducting, you will rescreen a child on any test that the child fails before you make a referral. You need to rescreen the child only on the test that the child failed. Then after rescreening, if the child still fails the test, you'll make the referral. The only exception to this is the color vision test. If the child fails the test after rescreening, you do want to notify the parent and teachers about that result, but you will not refer to a doctor for failure on a color vision test because there is no treatment for color vision deficiency. And remember, you may refer based on observation alone, but just use your common sense, confer with the teacher to find out whether the teacher has observed the same thing. And then, especially if you're doing mass screenings, you probably want to go ahead and complete all of the other tests just for confirmation of what you've observed and a stronger referral. Another point is, I think I mentioned this earlier in one section, but if there are multiple screeners in your school who are trained, it is always a good idea to switch screeners when you're rescreening, just because a child may react differently to a different screener or understand that screener's instructions better. What good does it do us to screen all of these children if the ones who have problems don't get to the eye doctor? That's why we need to do follow-up. Follow-up should be a systematic plan in order to be successful. I find that it's most helpful if I have a schedule for doing screening follow-up. If I pick a certain day of the week or certain day of the month, when I actually schedule it and make myself do it. You obviously are going to need some forms to go along with follow-up. When children fail the vision screening, you're probably going to want to notify the parent with some type of written documentation. And then you need to kind of talk about and develop a plan for what your procedure is going to be. You'll probably send a letter home, follow that up with a phone call. In a couple of weeks, maybe you need another phone call. But just keep working with the parent until you get some kind of result. I find follow-up is more likely to occur if I can offer the parent some names of doctors or resources that are available. And I think another thing to consider is that although there may be lots of obstacles to follow-up, might be lack of money or lack of insurance, difficulty getting off work to take the child to an eye doctor. Lots of times it's difficult to find a doctor who will see the child or accepts the right kind of insurance. A parent can overcome all of those obstacles, but the parent's not even going to try to overcome those obstacles unless he or she understands the importance of good vision for the child's learning, for the child's development, for the child's behavior. So if you can educate the parent about the importance of good vision and early treatment, that's probably going to have one of the biggest impacts on the success of follow-up. This is just a quick reference guide for your use. We've talked about lots of different tests and different tests for children of different ages, but this chart just outlines the different tests that are involved in a vision screening, which children need to take which test, and with what frequency and at what age. So just to reiterate, it is important to know a child's age when you're figuring out how to administer the vision screening for children. And another thing I would like to reiterate is sometimes you may have a crossover in age, especially in kindergarten. You've got some children who are age 5 and some are age 6. It's okay if you use the same chart for those children, but you do need to remember to use the right criteria based on the child's age. In many school systems, children are fortunate that mass screenings are done on a periodic basis, and hopefully all of you are able to perform those mass screenings. We do recommend that mass screenings be performed every year, pre-K through first grade, and then every other year after that, starting in 3rd grade. And these guidelines actually match those guidelines that are outlined in Bright Futures documentation. The screening tools presented in this training are all available on the school health website, and you see that website listed here. I've also listed the different product numbers for the different tools. The near vision chart, as well as some flip-up occluder glasses, are also available on the Good Light website. If you need any help with vision screening, questions about screening, you need additional training, you want somebody to come screen the pre-K kids at your school, please call Prevent Blindness or contact us at our website. We also may be able to help you with resources for children who need vouchers for free eye exams and or glasses. We also are able to obtain glasses for $25 for children who have lost or broken their Medicaid or Peach Care glasses and they need replacements, but perhaps they can't afford to wait another whole year till they can get a pair of glasses through their insurance, and they can't afford to pay for glasses in the meantime. We're also always available to answer questions you have about particular eye problems and diseases. Thank you so much for attending this training, and again, please contact Prevent Blindness if you have any questions about vision screening and vision screening training.